Oh, this is Cameron Sabat from Cutting to the Case, and today we are joined by Dr. Anand Murthy, a world-renowned leader in shoulder and elbow surgery. Dr. Murthy is Chief of Shoulder and Elbow Surgery at MedStar Union Memorial Hospital, where he also directs the Shoulder and Elbow Fellowship and research programs. He's Professor of Orthopaedic Surgery at Georgetown University School of Medicine and currently serves as Editor-in-Chief of Current Orthopedic Practice. Dr. Murthy trained at Case Western Reserve University, completed his residency at George Washington University, and pursued fellowship training at Columbia Presbyterian's New York Orthopedic Hospital. He's a past president and founding member of the Association of Clinical Elbow and Shoulder Surgeons, an elected member of the American Shoulder and Elbow Surgeons Society, and a recipient of the Castle Colony Top Doctor Award for more than a decade. His clinical experience spans complex reconstructions, arthroscopic innovations, shoulder and elbow arthroplasty, and sports injuries, while his research contributions range from biomechanics and surgical outcomes to implant design and registry development. He's published widely, taught nationally and internationally, and continues to train the next generation of orthopedic surgeons. We're thrilled to have him with us today.
Thank you very much, Cameron. It's exciting to do this cutting case with you, and it's great to see young medical students getting involved. And I appreciate the chance to do this.
Absolutely. That's what this podcast is all about. We appreciate you being here. So, our first question is, what drew you to orthopedic surgery and specifically the subspecialty of shoulder and elbow?
Well, I actually did a career day in high school. My father was a pediatrician, and then when I was in medical school, I actually wanted to do cardiothoracic surgery. So I had a ton of research done. I was wanted to go to Johns Hopkins with a special program. And then the last week of my surgical rotation, like you're doing right now, I spent that week with orthopedics, with orthopedic residents. We fit. I liked the research, the surgeries. And so then I flipped, and near the end of my third year, then matched at GW. Dr. Navaiser was the chairman there, was a world-renowned shoulder expert. So that was my influence, and then matched into a wonderful fellowship up in New York at Columbia, and the rest is history.
Yeah, and really building off of that, that actually led right into my next question, which was how did your training at Case Western, George Washington, and Columbia shape your clinical and academic trajectory? Were there any moments there that really were an aha?
All of those places, Case Western, George Washington, and Columbia, have tremendous mentors and educators where you were involved in clinical work really early on. Case Western was ahead of its time where we would be lined up with a pregnant mom the first day or first week of classes, followed them through to the delivery, then followed their postnatal visits. And then when I got to GW, we were really involved clinically, a lot of volume as interns and second years. So got our hands really wet early on. And then as a fellow, you really begin to hone those skills to become a great clinician. So all three of those places were really highly clinically, a lot of good clinical mentors and educators. And that's where you get excited to work, where you begin to keep learning and be involved right from day one.
Yeah, yeah. And really from there your career blossomed. You've now pioneered complex reconstructions and implant development. What innovations are you also most proud of, and how do you see the next frontier in shoulder arthroplasty and arthroscopy?
So just starting out, does getting into medical industry and designing is a very difficult process. You really can't do it on your own. There's some people who do want do it on their own. They completely go into their garage and DIY, and they want to design an implant or a suture anchor. That's really difficult without the resources of engineers and testing. What I'm most proud of about, I talked to you about Dr. Abood. We actually designed a proximal humerus fracture plate together many years ago. That was we did from bench research, biomechanics, all the way up to clinical studies. And then recently, about 6 years, I was fortunate to join this startup company called Ignite Orthopedics. We put together with a great engineer and great marketing person and six surgeons from around the country and designed an entire shoulder replacement platform from anatomic to reverse stemless that we then sold to a medical industry partner and is now being sold. Um, yeah, and then you keep looking for new innovation. It's not, there's all kinds of new innovations now. 3D printed rotator cuff, tissue augmentation, uh, 3D printed, a lot of the new implants are all 3D printed, which is patient specific. So you can design implants specifically for patients, and it doesn't take that long. It takes a couple weeks. So that's where innovation in the arthroplasty region is going to go, I think. And then on the kind of the sports medicine side, where you do rotator cuff repairs and fix people who have unstable shoulders and elbows. We're going to these really small anchors and what we call biologic anchors that increase the healing response. So the transition, things I've changed or learned over the last 20 years is incredible, and it's incredible to think what will happen in the next 20 years.
Absolutely. And that slides right into my other question, which was orthopedics is really becoming more interdisciplinary from that tissue engineering to AI. What fields outside of surgery do you think will influence shoulder and elbow care the most?
Right now, even in orthopedics and in shoulder surgery, we are seeing a lot of tissue engineering, 3D printing, and AI that is going to influence us, as well as the aspect of mixed reality, augmented reality, for us to be able to position and place implants as close to what we want to do as possible. So 20 years ago, we had just X-rays to do a shoulder replacement. Then we got CT scans. Now we have three-dimensional CT scans. Now we plan for surgery. Now we're doing just beginning robotic surgery, and then we'll incorporate mixed reality into robotics as well, all with the goals of doing the operation better, which then hopefully leads to better patient outcomes. So that's going to be and then AI is going to show us with the application of thousands or tens of thousands of patients, this patient X gets this implant because we've seen that over that many period of time and those numbers of patients. So AI is going to help us choosing the right implant too.
So, thank you very much for that perspective. Can you also share your perspective on robotic assisted surgery and its role in shoulder and elbow procedures?
Sure. So robotics has been around in orthopedics for quite some time, especially in the knee world, hip world for replacement and spine. Shoulder arthroplasty robotics just came out last year with one company. They're all competing. Obviously, it's a competitive space.
Mhm.
And it's going to allow us to position implants both on the humeral side and on the socket glenoid side even more perfectly than we'd like to. And we're actually probably going to incorporate MR with robotics as well, mixed reality, to do it even better. But it's still kind of in its formative phases. We're testing a lot of it now, but in the next couple of years, you're going to see shoulder robotics be prime time.
Absolutely. And really sticking to that theme of surgery robotic surgery and precision, how do you approach, revision surgery, where prior interventions have failed, both technically and philosophically?
So the revision burden, especially with reverse shoulder replacement, we have anatomic and reverse shoulder replacement, which is about 70% of the market now. So we are seeing a lot more revisions. About 20% of my practice is revision and growing, which means we have to think out of the box sometimes on how to replace what's already been replaced. And typically, people lose a lot of bone, so you have to build bone back up. We use custom prostheses a lot, which is designing with 3D printing, 3D modeling, a custom designed 3D printed, typically the socket, but also on the humeral side to fit what's missing for patients. So that's custom revisions are really exciting for me because you can really fix a bad problem. So I think that is going to be really important the next decade as we see that revision burden, but also, as we talked about before, we're going to have to design implants that are more easily revisable.
Mhm.
So we're going to have to build reverse shoulder replacements that are almost a platform system so they can be revised when they fail a lot easier than taking everything out, putting a whole new thing back in. So that's our plan for the next 10 years or so, 5 to 10 years.
Yeah, yeah. I mean, those custom approaches are really what drive patient care here. And you've also pioneered these really complex reconstructions and implant development. What innovations are you most proud of, and how do you see the next frontier in shoulder arthroplasty?
I think shoulder arthroplasty, we're going to be working on different bearing surfaces, which is important because it's all about longevity.
Hmm.
So designing implants that last longer and longer and longer. We're going to go to shorter and shorter stems. So I think stemless reverse shoulder replacement. So typically we put a stem down the inside of the arm bone, takes away some bone.
Hmm.
So we're always about trying to get bone preservation. So doing these replacements. So a stemless reverse shoulder replacement. So we're starting those studies right now. So I think those are going to be some of the bigger innovations in the next decade.
That would really radically transform how the implants even function, or how they perform. That's incredible. And really, behind all of this research, you are editor-in-chief of Current Orthopedic Practice, which is a huge role, and a board member for multiple journals. How do you view the role of orthopedic publishing today? I figured I'd ask the person for this.
Yeah, I mean it's important. I think as we talked about on offline, um, the publish or perish factors now with medical students and residents and faculty has led to a increase in submissions. So you have to be really careful on the quality versus quantity of what you publish, because once it's out there, it's out there. So we take a lot of time making sure that we choose and select the right articles, that they're peer reviewed, and so they can go out into the go out into the readership and really help to teach and educate. So, being a journal editor is kind of really overseeing that your mission on education is being taken care of.
It's really a huge responsibility, both to yourself and the field and everything. So, um, yeah, thank you for your leadership there. And really beyond that too, you've directed a highly productive research program and designed one of the first international shoulder registries. What impact do you believe data registries and outcomes research will have on orthopedics over the next decade?
So it's been almost 10 years now. Dr. Abood and I and Dr. Bell designed this shoulder registry for arthroplasty and actually for sports medicine, for fractures and things like that. So, just taking a step back, registries, there's no way to show your outcomes if you don't truly follow your patients. So I tell all of our fellows who go out into either private practice or academics, you have to follow your patients to truly show how they do, how the implants do, and track their function. So not only is it important to improve your patient outcomes, now we have insurance companies that are going to be reimbursing based on having your patients in some type of registry. So to actually follow how they do and make sure that they are, as their reasoning is to pay for the implants and the patient care, and these bundles of care. So we have to have them inputted into a registry as well. So, there's a few different registries. They're all very good. And unless you follow your patients, you don't really know how they do. You might think they do well, but it really gives you, at their 6 month, 1 year, 2 year, 5 year, 10 year follow-up visit allows you to see how they do and do they improve with time, decline with time, and we get to follow the implants also.
Yes, yes. And really once you follow those implants beyond just 2 years or whatnot, you can finally see, the modular high-risk orthopedic implants with reported failures and track company responses, between Biomet and
Sure.
Exactech and Smith and Nephew. There were a number of the Birmingham hip resurfacing A number of others come to mind, the Zimmer ML taper. There are a lot of famous cases where they followed the 510(k) process in the FDA, and they really, they were just looking for equivalents to the existing products, and they weren't doing like from the ground up, research studies on efficacy and safety. And so, that's really important to set up registries to be able to track patients long term and kind of create a paper trail there. So that's quite incredible. Then also, uh, as you're also a fellowship director, and what qualities do you look for in these trainees, and how do you think training has evolved since you were a resident?
That's probably the toughest question. I have loved education. That's kind of my in my soul since I started practice, and now for the last 13 years, I've run a fellowship, and so training is incredibly important. I'll start with that part first. Training has changed a lot with a lot more oversight from administrators, ACGME, both good and bad. We went to a shorter work week and had to work around that as well. So it's very different. You have to be really cognizant of their time and how education has changed. We don't do straight didactics anymore. I run a lot of conferences and meetings, and education has changed. It's a lot more short bursts of education, information, with a lot more testing and kind of back and forth. And then, choosing a fellow, I think it's really important to choose people who want to work hard and who bring a lot of energy. So that's what I look for when I'm choosing a fellow, is someone who really loves caring for patients, who brings a lot of energy every day. It's a long year, and who are willing to take good criticism because that's how you improve. And those are kind of the three big things. And we try to make it fun. Education can be fun as well. And so that's also been a big part of my kind of developing programs and training programs, is to make learning fun again.
And that's a huge goal. And it reminds me of that famous adage in surgical training: be able, affable, and able.
Hmm.
Yeah, that's just a fantastic approach. Really, just be hardworking, be present, and be ready to learn. And looking back, my final question: what do you hope your legacy will be in orthopedic surgery, both for your patients and for the field as a whole?
My legacy, I hope, I think we forget how much we affect patients and how they improve. We run through busy weeks, and I often stop and tell my staff, I'm like, we really helped a lot of people every day. And so we have to realize that. So I think that's a great legacy, simply to have that you really helped patients over whatever period of time. Um, and then I hope I'm remembered as a good educator. And, I've paid it forward by training a lot of fellows and residents, and hopefully they've gone on to take care of patients really well also. And so we've set up a good way to really improve patient outcomes and make people's lives and quality of life better. And, I think that's a good goal to have.
And you know what they say about educators and teachers, there's no way to quantify your impact because it's exponential. I mean, you just train these people and they train more and more, and it's
Right.
just ripples in the world. So
Right.
I,
Right.
I appreciate you doing this. Thank you. It's incredible. And I appreciate you joining us today on Cutting to the Case. Do you have any final words? Anything you'd like to share with our audience, or
Well, first of all, I think this is an incredible format, Cameron, and
you?
you're doing a great job because education and information is so digital now. And I hope you continue to do it. You're going to do great things in orthopedics, I can tell already. We're kind of connecting the world now. So, congratulations to you on this format, and good luck in the future.
Yes, thank you so much, and it was an honor to interview you today. Till next time, this is Cameron Sabat from Cutting to the Case.